the goal of this presentation is really the core of what the AOM is, which is to bring people together to say how they evaluate and decide how to treat the same kind of case. Because it's not about we all inject different things, it's how do we think about the patient in front of us. So everybody here is involved with both regenerative medicine and their own specialties. And so it's really understanding how we all became essentially hybrids of our specialty to form what is for all of us our medical home, which is the AOM. So all of us have different backgrounds and approaches, but this is home where, you know, we feel like we're amongst our brethren. We all think similar ways. And for people who live in very communities where you might be the only one doing this, it's really nice to have a place where you go, I'm not the only one. So where I live, the nearest person who does what I do is Paul Tortland, who lives in southern Connecticut, okay? And that's 275 miles away, and it's terrible. I wish someone was 2 blocks away. By the way, competition is good. It makes you busier. So with that is, how would these different background people treat the same case? So Dr. Scheipel is osteopathic sports medicine. Dr. Lieber, where is he? Raise your hand. Is physical medicine, interventional spine. Dr. Osborne, family practice, osteopathic medicine, orthopedic medicine forever. I think you're forever. Oh no, John's past you. John Finkelstadt is family practice, sports medicine, pain, and the oldest sitting president in the room, I think, of this organization. And Neil Kirshen is a born-again osteopath, MD, anesthesia pain person. So the first case is kind of a common case we all see, and what the case is, it's a 65-year-old male, normal weight, active individual who comes in with medial knee pain, and you do your exam, and everyone will say what they expect to find, but the sort of thing where the sort of narrow focus is he has medial joint osteoarthritis with grade 3 and 4 cartilage changes. Underneath the bony spaces, his subchondral space has bone marrow edema without cystic changes or AVN, and you know, he's got medial knee pain. So without going into more of a history, I want each person to say how they would evaluate them, what they think they might find that's important to treat, and then how they would go about treating. So who wants to start? Carl? Brian? Whatever. Anybody. So we're looking for like 90 seconds each.
Well,
only because we're late.
One thing I would say, just for those of you, if you're new to this organization, there is no real specialty training that encompasses the breadth of knowledge that you'll get in an organization like this. And so we all kind of come from different backgrounds and become broader thinkers. But in regard to this particular case, you know, nothing ever happens in isolation. And so somebody has medial knee pain. It's not like we're just treating the medial knee. We're looking at the organism as a whole and evaluating posture. And, you know, I always evaluate biomechanics, and I look from the ground up. So if somebody has medial knee pain, I'm going to be evaluating their foot biomechanics, their arch, their stance, their posture, their gait, all those things, because it's like the foundation of a house. If you have a problem with the foundation, it's going to affect everything above there. And so, you know, just looking at the knee in isolation is a very simplistic and isolationist way to approach things, and I think that most of the people in this group would agree that we look at the person as a whole and then treat the specifics, such as the knee. In this particular case, you know, we already have an MRI. We know there's bone marrow edema, and that may or may not need to be treated with interosseous stem cells or interosseous PRP, but just in a greater scope of evaluation, you want to, I think, again, look at their posture, their stance, look at the foot and ankle biomechanics, and then treat locally but evaluate more globally. And that might include, just for specifics of, you know, one of our regenerative injection techniques to stabilize the knee. There are particular braces, medial unloader knee braces that can take pressure off the inside of the knee and do correct biomechanics, look for the fascial connections and the rest of it that we've been talking about so far today.
However, but before we do that, how do we get them into our office? I think we have two types of patients. We have the enlightened patients and we have the average patient. The average patient is going to be coming to your door. Do you take their insurance is the first question. They used to call up and say, how are you with knee pain? But they'll call up and say, does your doctor take insurance? So we have the insurance covered and then we have the non-insurance covered. And I think one of my roles on the panel today is to tell you that you can be the Brian Scheipel of our day, who's brilliant and knows how to treat so many things. But I can't get them into the door if I don't take their insurance. Once I see them, I then can figure out how to start the conversation. So I'm on the panel to discuss acupuncture. I think acupuncture, I'm not going to tell you at this point now how I would treat, but to get them through the door, I say, you have a knee issue, you have other issues we're going to be talking about. But before they leave your office, they're going to say to you, what are you going to give me? It's talking about Richard Gracer. What am I leaving with? Well, you have two choices. You can either knuckle under and give an anti-inflammatory or a opioid, which we don't want to do, or we can offer a symptomatic treatment. So for a particular patient like this, I've gotten them into the door. I offer them a low price type of treatment of acupuncture. If it's not covered, some insurances do cover it. And when they leave the office, at least they had a treatment of something of symptomatic value. Once you capture the patient's attention of making them a little bit better, they are now yours. Whether you want to talk to them about tensegrity, when you talk to them about the role of prolotherapy and PRP, I find that comes a little bit later. I start the groundwork on the initial consultation, though, with all the treatments that I think would benefit them. We can also talk about how their diet affects that. But before they leave the door, I think the acupuncture is a nice place to start. It doesn't hurt, it's low cost, and it's a nice introduction into your practice. If they don't come back after one acupuncture treatment, they're definitely not coming back after one prolotherapy treatment. That's how I kind of would start.
Take a step. So on a case like this, we do all the things that we talked about here, but on the evaluation, I want to know how this patient knee is functioning. What's the instability evaluation look like? Does this patient have medial instability? Do they have tenderness over the coronary ligaments? Does that protruding meniscus? Are they having any catching? Is it torn? How badly is it torn? What's my chances of healing? The severity of that tear versus sending the patient to surgery. So I try to give the patient the most accurate diagnosis I can, and then we get into a long discussion on treatment options, and I start with my recommended treatment option. And my recommendation is to try to get them, with my experience of doing this for a long time, as best as I can in a knee like this. We're not curing them. We're trying to give them good functional stability, good pain relief, and heal as much as we can, but that knee is going to go on to do worse over time. We're probably slowing that process down with the best available treatment we have, but we're certainly not curing arthritis yet. So in a case like this, I want to know, do they have rest pain at night? Does their knee wake them up? If they have bone marrow swelling on the MRI, that's my clinical indication that bone marrow swelling needs to be treated. If they have no rest pain, and they have a small amount of bone marrow edema, even in grade 3 arthrosis, I won't offer them an intraosseous treatment. They'll do fine just going intra-articular and taking care of the rest of the organ as you're trained to do as a prolotherapist. And then what you choose in your syringe depends on what the patient is looking for. Can they afford what I would call an optimal treatment, or do I have to back it down to something that they can afford? So that's the way I approach a patient like this. And, in many cases, most cases, these patients do quite well. And of course, we're taking care of these patients with the osteopathic philosophy of taking care of the whole patient as well.
I'm not sure I have much else to add, but when you think of a knee case, you're thinking about weight loss, you're thinking about orthotics, you're thinking about a proper diagnosis, you're thinking about talking about options. I live in upstate New York. I don't think there's as much disposable income in my area as in some other spots, like Long Island, for instance, or Philadelphia, or Pittsburgh, or Washington State? Oregon. You're in Oregon, okay. So I try to work with their insurance, so you can talk about if they haven't had viscosupplementation. I'll sometimes try that on the patients. Sometimes it works, sometimes it doesn't. I've started to use a fair amount of prolozone in the last 5 or 6 years. I think that can help some patients. I try to avoid corticosteroids, and of course we're using standard prolotherapy treatments as well. So you try to, as I said, I think the comments you made, Neil, were good. You want to get them to trust what you're doing, and then try to work with them if you can, but give them your honest opinion and go over the different options. So, yes, Paul.
So I guess as the interventional spine guy, PM&R person, I would do a comprehensive neurologic exam to see if there was nerve issues related to muscle imbalance, possibly related to a smoldering radiculopathy that I would address in addition to everything that's already been talked about, looking at the person's knee specifically. So I may suspect that they have a spinal problem and address that as well.
Great. So what you got is, I'm going to take questions, is everybody approaches it differently, but we're all trying to remember dynamic functional biomechanics. And so the only thing I would add is, notice nobody said what they inject. What you inject depends on your relationship with the patient and what's best, but as Brian said very eloquently, you offer them what you think is the optimal treatment, and then they're more likely to do that because they're coming for your opinion. If you offer them a laundry list, they get confused. So sure, I even inject sodium bicarb and calcium gluconate because somebody published an article on doing it monthly, and it was convincing enough that I got my regional Medicare CAC to say it was okay. So I do that to all that burned out old farmers I see in northern Vermont. But the point is, it's not what you inject, it's how you approach the patient and actually capture the patient in an honest way. Question?
Yeah, the question was for the edema of the bone from the arthritis. Someone mentioned there's intraosseous injection, and when, and then I'll ask what, and then how do you do the injection? What kind of guidance do you use to do that?
Yeah, I'll let Brian address that. A lot of us do it, but Brian will give you that one.
So when do I inject? If, again, the patient is symptomatic, they're at rest. These patients have, that bone edema is a source of pain in those patients. Some of these patients will have pain at night that'll wake them from sleep.
At night.
And those are the subchondroplasties that the orthopedic surgeons are doing, and we're getting very similar results, putting either bone marrow in, and the Spanish surgeons, Sanchez, et cetera, are doing PRGF in the same area and getting good results. Where do we put it? On the medial, if it's a medial femoral condyle, we'll go in under C-arm guidance into the medial femoral condyle, medial to lateral, and the tibia, medial to lateral as well, pretty close to the cortex of the bone where the bone marrow swelling is. I try to get it into that area of the bone, and then we'll put a volume of bone marrow concentrate in, or PRGF is what's commonly being used.
Can you visualize?
So most of us use ultrasound to make sure we're not near neurovascular bundles, and then put it in under C-arm guidance, and they make these hand-turned 18-gauge bone marrow trocars that are inexpensive. You don't need a fancy device. And if you do a really good high saphenous nerve block, you do not need to sedate these people.
And also add geniculate nerve blocks as well. They help a lot.
Yeah, I only sedate people because they're anxious, not because it hurts. But make sure your nerve block works first.
Yeah, some patients will have, even with a good block, they'll have a significant sensation to the pressure change as you're injecting.
The bone marrow.
And that can be very uncomfortable for them. So you have to slow it way down. We'll use 1cc syringes to get the bone marrow in. Pardon me? We'll do saphenous and geniculate nerve block. Yeah.
You can do a femoral, but then their legs out, and then you have to get them out of your office. Andrew? So if the bone, Wolff's Law, bone responds to underlying force. If it sees too much force, what you're essentially getting is microfractures of the trabecula, and you get edematous swelling. And as Brian says, the people who have pain at rest, and especially pain at night, they've really shown that bone marrow edema is very painful, and especially in people younger than 60. It's very painful. Oh, sure. No. No, we all use unloader braces.
It's a phenomenon of grade 4 arthrosis. So you're no longer getting any hyaline cartilage protection of the subchondral bone. And over time, it'll start as a small focus on MRI, and it'll get bigger and bigger and bigger until it can involve the whole hemicondyle. And that bone can go to failure and can collapse and cause tibial plateau fractures, and then the joint's done.
You just send them. It's to prevent progression to cystic changes, avascular necrosis, collapse, bone death.
So to your point, Andrew, I had a national caliber triathlete who stopped running and his bone marrow edema resolved spontaneously. So it can happen just by stopping the loading forces that are occurring there.
You can get subchondral edema on the other side of an osteochondral defect. And we have ways to treat those now pretty effectively, including surgical stem cell that Dr. Gobi presented last year very eloquently. And he is getting all of that to resolve. There's a Dr. Fleischer is an pediatric orthopedic surgeon in Ohio that is doing retrograde drilling and putting in bone grafts with bone marrow concentrate into the bone marrow edema and actually healing from the inside and out. And so there's lots of good work going on, but we're talking about a grade 4 hemicondyle that's bare bone, I believe.
Yes.
Yeah, so that's an end-stage case.
In my area, I've actually gotten one orthopedic surgeon to do bone marrow concentrate intraoperatively, through drilling for osteochondral lesions in people under 25. And no, this was grade 3-4 medial joint arthritis with bone marrow edema. That was it. So we're going to move on to the next one because we want to get a few cases. So let's see if I still have a computer. I do. All right. Do I like this one? Yeah, this one's reasonable. So in your practice, you may know the expression that when the student is ready, the teacher will appear. Everybody know that one? And so what happens is when you're doing this work, as you get better, people show up with more and more and more complex things. And sometimes I'm doing cases and I went, gee, can I have something simple where I don't have to do 16 things to this person at once? And, it's all gone now. Nothing comes simple anymore. We all have that experience. But, if you gave me these people 10 years ago, I would have been overwhelmed and not treated them. So this case is one that I see all the time, and I'm going to love the panel's discussion of this because it's enormously broader than what I'm about to present, which is a 45-year-old man who had a traumatic injury to his shoulder, doesn't matter how, and he comes in telling you that I was going to have surgery, but I decided to try you first. They always do that. And then, of course, they tell you, and if you fix it, I have 150 people to send you, and no one's following him, so don't listen to him. Okay? No pressure. They all say that. So he's 45. He comes in. and he wants you to look at his MRI first, which I personally refuse. I examine people first, or have you read everybody's consults. And I always say, I don't read anybody's information. I make my own decisions. Talk to me. So, but the case is his MRI says he has a complete non-retracted tear of his distal supraspinatus, and he has a non-displaced superior labral tear as a slap lesion, type 1. And everything else is fine, which we don't believe. MRIs are not very accurate, everybody. Ultrasound's more accurate for the cuff. And on physical exam, the thing you get the most is that he has excess posterior to anterior glide, so he seems a little unstable anteriorly. And when you do a sulcus sign, he's got like 2 fingers of instability, right? So he's got anterior and inferior instability on your instant exam, and the rest really doesn't matter because the reliability of physical exam in the shoulder is very variable. So with inferior and anterior instability, a slap tear, type 1, and a non-retracted complete supraspinatus tear, but nothing else, who's starting?
Oh, I'm going to start this one. Patient like this comes in, I tell them, you are not an acupuncture candidate. This is something that we can help. I say, how's your low back? How's your neck? Any knee pain at all? But do you like your mother? Any stress in the family? Other than that, you're not an acupuncture candidate.
Very well said. Of course, we're going to do a physical exam and a history, but then we're going to do a very thorough diagnostic ultrasound of that shoulder. I don't necessarily get MRIs on all my shoulder cases, but we're going to do a diagnostic ultrasound. We're going to try to correlate the findings on the MRI if we can, and then we're going to go over some options for them. This guy, if he does have a complete non-retracted tear, I'm going to lean towards treating him with guided PRP. And if we have a patient in that just has tendinosis and an exam doesn't have a tear, I'm probably going to use on a male patient. I'm going to probably use testosterone prolotherapy on him. We've had some very, very good results with that. They're going to need more than one treatment. They're going to need some activity modification. They're going to need, of course, they're going to need some follow-up. I followed up a couple of cases by phone last week just because I wanted to know how they did. And I think that's very, very important to follow up and know how these cases are turning out. And so we're calling all our patients and follow up to make sure that we're doing the right thing for these people.
Could you describe briefly what testosterone prolotherapy is and what you would think you were injecting?
What do you mean, as far as
structures?
Are we doing like, for instance, if he had a supraspinatus, we'd be doing a standard prolotherapy treatment. Have we shown this in class?
Just explain them what structures you're shooting, buddy.
Okay. So for those of you that have done ultrasound, you know you have to put the shoulder in different positions to get at each tendon. So we do that, and usually I'll draw over their tender areas or the areas I want to treat. There'll be a trapezoid over each one of these tendons, and you're going to do the supraspinatus, the subscapularis, and the infraspinatus tendons, and then you're going to pepper those tendons starting from the bottom up with a 25. I use a 25 gauge 2-inch needle.
Okay. And what's your concentration? What's your solution? Just so we might
well,
the
testosterone. First of all, we're using an aqueous testosterone solution, which is compounded, and I checked our college has it available for you. And we put in, that comes 50 milligrams per ml, and we're going to put, our starting dose is going to be 0.5 in 10, and I'm going to be using a very dilute lidocaine solution with that.
So 25 milligrams of testosterone total in the treatment?
No, if I was going to treat more than one tendon, I might use as much as 20 cc's to treat 3 tendons. I'm injecting the heck out of it.
This is a male, don't forget, this is a male.
Well, we've treated females as well.
Same dosing? All right.
Depends on who you listen to.
Okay.
You might decrease your dose in a female patient.
All right.
Yes.
25 ml intensity.
Yeah, your range,
25 milligrams
your range would
intensity.
be 25 to 50 and 10 ml, but
I use 5.
So I would, what was the question? That's what he said.
Right.
yeah, the doses are not big.
So a couple of things concern me about a case like this is the degree of instability from this labral tear. This patient has a destabilized shoulder, and they're probably impinging. Is this patient impinging? Let's say he's
what's written down.
impinging. Let's say he's impinging. So now I'm concerned that if I do a biologic treatment to this full tear of the rotator cuff, what's the chances of the impingement being corrected by our treatment, A, maybe even with follow-up physical therapy, B, and if they fail and we haven't corrected the impingement and they have subacromial bone spurs in the bottom of an arthritic AC joint or downsloping acromion with a hook spur on it, that could rip open your biologic treatment in the course of their healing process, and you get failures. So the MRI is imperative for me. Before I'm going to put a multi-$1,000 treatment in this patient, I want to know if they have anything that's going to put their treatment at risk for failure. So I will get the MRI, and if I see anything that I cannot handle on our treatment, I'll send them first for surgery to do a subacromial decompression, and then bring them back about 6 weeks later and do the biologic treatment. And in a case like this, if it's a full thickness rotator cuff tear with minimal retraction, my treatment of choice would be it would be a bone marrow actually. And the reason I would pick a bone marrow as my treatment option, my best treatment option. A lot of these patients come to me from pretty far away, and I want to give them a single treatment. So I call them one and dones. So if they want a one and done option where they're traveling in and going back home to heal, I'll offer them a bone marrow. That's my highest success case. If they're a local patient and that we have time, then I'll do a PRP program, maybe a PRP with a graft. And the two grafts I use are amniotic tissues and the patient's autologous fat. We'll make sure we hit anterior capsule, posterior capsule, inferior glenohumeral ligament, and tack down the labrum with a biologic agent with a graft. And if the patient has any tension on that rotator cuff, if there's any gapping, we'll consider putting 100 units of Botox into their muscle using ultrasound guidance to rest that muscle for 3 months and allow that scab that we put in their tear to heal. Okay? So, and then at 3-month mark, they begin full rehab. They start the rehab at 8 weeks, and they're doing minor things. And at 3 months, they go to heavy-duty exercise, focused rehab program to get them back to life.
You got to treat more than a tear is basically the thing. You got to treat
Right.
both.
Yes. Yeah. So that, and most of these patients, even with just this isolated rotator cuff tear, they have some degree of capsule work and labral work that I need to do.
Sure.
If you're putting Botox in and you're putting the muscle to rest for 3 months, how are you going to start them at PT 4 weeks out? Is the muscle going to...
Not starting them at PT at 4 weeks out. So the question is, for Botox, how are you going to start rehab at 4 weeks after Botox?
Or 8 weeks?
Yeah, so 8 weeks the Botox is wearing off on a muscle that size. So they're starting to get some activity back, and it's fully back by 3 months. So we're doing a lot of scapular stabilizer muscle work and using the other muscles around the shoulder.
Where do you put the Botox?
Into the muscle.
Which muscle?
Supraspinatus, where the full thickness tear is.
You know, I mean, the supraspinatus isn't the most important muscle. It's one that hurts the most. It's one that's caused the most trouble.
I'm trying to heal the tear, though.
But you can rehab their infra and subscapularis muscles and get them stronger. That's where the stability for the joint that keeps the head in the glenoid fossa, those two muscles. I mean, yeah, you need to do the supraspinatus Botox rehab.
You can rehab them during.
Or the supraspinatus recovers. You don't have to rehab the supraspinatus to rehab the
I'm trying to, so the Andrew's point is you can do rehab early in the face of a treatment like this. In my experience, if we rehab too soon, just like surgical repair, you run the risk of re-tears. So I'm trying to get that tendon, and I have a talk that I was going to give at this conference that I just gave a couple weeks ago. And one of the cases we showcased was a full thickness supraspinatus tear, 1.6 centimeters retracted. And we did this protocol to this patient, and the tendon looks perfect. And she had full recovery at the 12-week mark. She went to finish full rehab for 4 weeks and jumped back into her sport, which she hadn't played in about 6-7 months, which was pickleball. And she went to the national tournament and won bronze. Yeah, so point is that tendon held up, and she came back for serial ultrasounds every month out to 4 months, and you saw the progressive healing of the tendon filling in.
Let's wait questions until everybody gives their talk.
Again, not an acupuncture candidate.
Yeah, I look at injuries like the shoulder, and of course the great deal of the focus is on the full thickness supraspinatus tear, because that's what people want to send to the surgeon, and if you're trying to avoid surgery and look at other alternatives, then that's sort of the focus. With a full thickness tear, I usually recommend like a stem cells with partial thickness tears or more tendinosis. Then you can look at PRP treatments or prolotherapy treatments. But with this kind of injury, I think no matter what you're treating it with, you really have to use imaging guidance to really place it in the tear to get the best results. And the other parts of the tear, the slap lesions, so we know that they have a superior labral tear, they have inferior instability. And what Brian said really is key. You have to stabilize the shoulder. They're just going to have the same problem back again. And so really looking at the biomechanics and the myofascia factors that affect the shoulder are critical. And with an injury, you're going to develop scapulothoracic dyskinesis. And after a treatment like this, you're going to have scapulothoracic dyskinesis. And so a big part of the treatment on the other side of the treatment event is going to be the rehabilitation portion with the neuromuscular re-education and the strengthening and the rehabilitation of the shoulder. And so that's all, I think, a very important part of the process.
One other thing that I want people to think about, and again, this is spinal related, and that is, what's your C5 spinal nerve doing? How is it supplying your supraspinatus, infraspinatus? What's the quality of that muscle? Because if the muscle quality is diminished, you're less likely to have a successful treatment. So, you may again be looking at doing a C5 transforaminal injection or series of them in the case of C4-5 foraminal stenosis.
Yes, question? Front row.
Yeah, I have a quick question. You guys don't say about the rotating interval, because the rotating interval is very important stabilizer for the supraspinatus and the subscapularis and the biceps long hand. So the lung region is very correlated to the stability. But you guys don't say that the rotating interval. And the second question is the scapulothoracic dyskinesia. What program for the rehabilitation about the scapular dyskinesia? You focus on the stratus anterior or the trapezius or the other things. What's the focus on the scapular dyskinesia rehabilitation?
I'll take the first part. For the rotator cuff interval, that was not presented as part of this case, so I didn't address that. But we absolutely, during the diagnostic exam of the rotator cuff interval, will assess that and look at the superior glenohumeral ligament, the medial glenohumeral ligament position of the biceps, make sure it's not subluxed medially underneath the subscap, and those absolutely have to be surgically corrected. If that biceps tendon has come out and has slid underneath the subscap by ripping the subscap off the lesser tuberosity, There is no injection that we do in the world that can get that anatomy back together. It has to be reconstructed. Okay, and I see those quite often in our patients, usually athletes that are throwing athletes. So yes, we do look at the rotator cuff interval and make sure it looks healthy and stable. And if there's any biceps tendinosis or partial tears, we'll address those with an injection of whatever to help it heal. Okay. Anyone else want to take the scapular dyskinesis? I think you just addressed it, Carl.
Yeah, as far as the rehabilitation, with a severe injury like a full thickness tear with minimal retraction, again, I would, probably address that with stem cells directed into the tear, and then with the rehabilitation, you're not going to grow significant new tissue for 6 to 8 weeks after you do the treatment, and you want to protect that structure during that time. I don't do a Botox injection like Brian does, but that sounds like an intriguing concept. But as far as the rehabilitation portion, there's multiple muscles that affect the shoulder girdle. The trapezius is a big one, and you have the serratus anterior and all the rotator cuff muscles. And so you don't rehab any one of these in isolation. When for that first 8 weeks, you have just a more passive movement type of things. You don't really want to be doing a lot of exercise or resistance things that could potentially cause further damage. And so then once you hit about that 8-week time interval is when I start having them do some light resistance training, and you're addressing all of those muscles. It's not just the rotator cuff muscles that you're addressing.
All right, I'll just add to that. The problem with the scapulothoracic dyskinesia is one of the better models that we have is the non-religious postural restoration model. When I say non-religious, some PTs only do postural restoration, and so they work on your breathing for 6 weeks. So the ones that are more holistic and mix things will get their ribs and respiration moving first, then get their recruitment pattern to get them out of these poor recruitment patterns. So at least for me, it's postural restoration and functional movement patterns that seem to work better to get these people faster, not concentrating on serratus strengthening or trapezius coupling of upper, getting the lower trapezius to work better. It's more doing that with the postural restoration and functional movement. They tend to get better faster and safer.
The biggest thing that changed, I think, we're dealing with these problems in my office is when we started routine comprehensive ultrasounds of all these shoulder cases. That correlated with once we started with that, it really changed the way I thought about a lot of these cases and changed our treatment approach. And so I would encourage you to, obviously, if you're not doing that now, you need to be doing that.
And it's dynamic ultrasound. One thing,
Yes.
Once you learn ultrasound, is you're doing ultrasound while they're moving and while you're stressing. So, Ed?
So I agree 100% in terms of the way I want to treat that patient. The only thing I might add is some things that I might do would be looking at perineural trappings as a possibility for that supraclavicular plexus in that whole area. And also, I like to bring them back once a month while I'm kind of to give them a little fertilizer therapy to help along the ramp that you've got going during that time period.
Absolutely. If the patient has other concomitant issues going on around the shoulder girdle up into the neck, if it's perineural, if it's a supraclavicular nerve entrapment, and they're getting some, skin roll positive testing that we do as osteopathic physicians, that would be my clue that I might be trying to calm that stuff down. Some of these patients will come in, they've had their tear for a long time, and they have thoracic muscle, not only imbalances, but on diagnostic ultrasound we'll find muscle strains in the iliacostalis and in the multifidi and whatnot, and they have these knots. They come in with these devices to work on their knots, and we'll find stuff back there that we'll treat, and it'll heal up as part of their course of treatment.
say, look, I'm gonna do this, but it's gonna take 4 to 6 weeks before the tissue comes back. It says to me, well, I can go to an orthopedic surgeon, he can drill it and put it in there and get it stabilized, then I can come back to you for the residual.
There's actually good literature to show it takes 4 months for the tendon to fill back in after surgery. And if the patient's over 60% of those patients will re-tear within a year. So your point is well taken. What I explain to patients, most of the patients that come to me are looking for a non-operative option. I don't have to really talk them into much. And if we do get into a surgical discussion, I explain the options, always give the patients the surgical option as part of my consult, and say, why would you want to do this? This is the reason why. Our failure rates, at least, I don't have an RCT to go back on and say this, we have a less than a surgical failure rate, but anecdotally in the many years that I've been doing this, it seems like these patients are doing better than surgical when we get a good repair. Sometimes I pick a tear that's too big, or the patient's not compliant enough, or they're too sick and they didn't heal enough. And some of these patients don't make it, and we have to send them to the surgeon if they want to go to surgery. Some of these patients will end up living with it.
Okay, thank you.
Okay.
Remember also that, people are given poor information about the pain and rehabilitation period post-surgery. For anybody who's had surgery and is in an airplane splint, it's very long. A lot of us treat a lot of ACLs, and they're back fast and they don't hurt. Anybody who's seen ACLs who had the surgery, a lot of them are still suffering in a year. Yes, their knee's tight, but they're suffering. So, the conversation of surgery not is actually pretty easy when you expose the real facts of pain, post-op complications, risk. It's usually not hard, but as Brian said, most people are looking for a non-surgical option and also a way to not miss that much work.
Yeah, I would just add something to that because Jonathan made a great point. I was going to say that, for people that have had rotator cuff repairs, that's one of the most painful orthopedic surgeries you can rehab from. And I know because I've had it done on both shoulders, because I had it done before the kind of stuff that we're doing now was available and existed. And the other thing I'd like to just point out is that many of the people that I see who've had rotator cuff repairs a year, 2 years later, they still have constant pain and they have a functional shoulder, but they still have the pain, and I end up treating those people to get rid of the pain post-operatively.
Remember, ligaments are not addressed. When they tried to address ligaments in the shoulder with what's called capsular thermography, they ended up with frozen shoulders. So, the whole concept really of orthopedic medicine is stabilize the static structure, the ligaments and the static structures, and then the dynamic structures. And, surgery treats what you can with surgery. They do not address all the tissues. No?
Yeah, Brian, you mentioned osteopathic changes on the bottom of the AC joint. And I use like a very dry technique to break those down. Have either of you or any of you use that method or try to resolve those osteopathic?
I can't see underneath the AC joint without a scope. I am trained to use the MyEye. I have not. I need to go back and do like a year fellowship in orthopedic surgery to get to that spur. So, how do you get underneath the AC joint?
Are you using going through the chromioclavicular notch with a bent needle, similar to what we do with the
But at that point, are you blind with the tip of your needle? Yeah. Okay. Okay.
All right, let's take one more question and then I'm going to move on. Yes?
So the question is, when do I use an amniotic tissue graft versus an autologous fat graft for something like a rotator cuff tear? It's personal preference for the patient. I'll explain that the amniotic tissue graft is not their tissue. It's not a non-autologous. Some of the patients, once they understand that, they say, hell no, you're going to use my own. So I want to make sure, and we have consent and whatnot to use that with them. I don't know of, does anybody know of any disease transmission or infection using the amniotic tissues in the last like 5 years that we've been using them? I don't know of any.
Stuff I use is gamma irradiated. I'm not too worried about it.
Yeah, so, but what I see, and Mike Scarpone has eloquently presented his work and the tissue recovery using a amniotic tissue graft with PRP or by itself. The recovery is better and the patients heal somewhat better. I explain to patients in our hands now, we have enough experience to show that it seems like it works about twice as fast as a PRP, or about twice as strong. So one PRP or two PRPs would equal one PRP with an amniotic tissue graft in a significant defect, like a meniscus tear, a labral tear, a rotator cuff tear. If I need 20 cc's of autologous fat mixed with PRP to treat large muscle tears in the hamstring, I'm not going to pick an amniotic tissue graft. That would cost $20,000 worth of product in order to get the same volume of fat. The other advantage of fat, it's a cellular-based product. It has stuff in it that is probably going to make it stronger than just a PRP as far as the healing effect of it. And we do see very efficient healing in muscle tears with PRP fat grafts.
Is it cryopreserved?
What's that?
The amniotic, is it cryopreserved?
So the question is, are the amniotic tissues cryopreserved? They're usually not. The morselized, gamma-radiated, dehydrated is like a little white powder that comes either suspended in a little bit of solution or it's dry, and then you reconstitute.
Understand that most of us, if you're being honest, these are low growth factor content basement membrane collagen grafts. And basement membrane is amazing stuff, but it is not a cellular product.
Yeah, it's not cellular.
If it's cellular, it is illegal to sell it in the United States. So they are not cellular products. No matter what the ads say, they are not cellular.
And what your reps say.
But basement membrane, you put basement membrane in blown out muscles and they regrow muscle. Basement membrane's magic stuff.
It's got good stuff in it.
But you just gotta, there is science. So we're gonna go on to one more case because we're all kind of late. And so we're gonna do a back case. And so the thing with back cases is no one's gonna give you the physical exam because what I think is important on a physical exam is so osteopathic and fascia, and I don't really care about the MRI that much, even though I get them and you treat partly. But again, try not to treat the MRI. Part of what, as Neil said, part of having a business plan is to honestly be able to get people who come see you, consult with you, and then convert to be your patient, whatever you do. And so if you're like everybody else, they're not going to stay. And those of us who have significant amount of practices that are cash, where I live, the average income is even lower than where John Finkelstead is, and yet I'm really busy, okay? And if you drive an hour from my house, there aren't 150,000 people in that circle, and yet I'm really busy. Why? It's not sales, it's giving people options so they know that you think about them and care. So you show that you're thinking about it. So this case is it's a 31-year-old female with 2 years of history of low back pain, both axial and radicular. It's worse with prolonged sitting, and she has pain that's not only in her low back band-like, but it goes down the PSIS area a little bit down lower, and it wraps around a little bit to her groin, and she clearly has pain down to the bottom outside of her left foot. And so the MRI shows a high-intensity zone disc that's about 4 millimeters to 5 millimeters protruded posterior laterally on the left at L5S1. She has 90 to 95% of preserved disc height. She has, it's not a dark disc. It looks like a good disc. She's in good health. And the facets do not look degenerative. The physical exam, everybody's going to fill in what they find because it'll give the whole thing away. So I'm going to, with the panel, it's not just how to treat it, but what do you think you're going to find on physical exam that's going to guide your treatment to where and what you're going to do, okay? So whoever wants to start.
So physical exam, you're looking for signs and symptoms of an S1 radiculopathy, which is going to help guide your exam. So neural tension signs, whether they be straight leg raising or compressing the neuroforamen at L5S1 by extension and ipsilateral rotation. And also whether that triggers facet joint mediated pain will tell you something. The end result is that you've got instability at L5, S1 with reasonable residual disc space height. So I think you're obligated to treat the instability first. So what am I talking about? I would use biologics and treat the spinal segment, the areas above and below. I may want to treat the SI joint ligaments and look at muscle imbalances as well. I would always treat the posterior elements first. They include the iliolumbar ligament, the supraspinous and interspinous ligaments, the deep interosseous, not the deep interosseous ligaments, the ligamentum flavum. And I may treat the deep interosseous ligament, very frankly, because that may be part of the source of the pain that's referred into the inguinal region. I would do transforaminal epidural at S1, probably with platelet lysate. Some of you don't have that. You can use platelet releasate. They're strongly anti-inflammatory, and I would treat the ligaments and the facet joints most likely with the biologics with superconcentrated platelets into the facet joints. Treat the multifidi as well if there's some atrophy. And then depending upon how that worked, you can pat yourself on the back and say, well, I've stabilized the person's lumbar spine. They're still having sitting intolerance. It's time to now go into the person's disc. And you do so with a great deal of concern because you're taking on an area that can cause discitis, which is a problem if that occurs. I would then go into the disc with biologics. I'd treat the nucleus. I'd use bone marrow concentrate and platelet-rich plasma combined together. I would treat the annulus, and on the way out, I would do another. In this case, on the way out, you're doing an L5 radic treatment with platelet lysate. But that would be secondary. I would not jump into anybody's disc first. I would try to stabilize the posterior elements before I would address the disc.
One of the things that has been mentioned in this conference before is that we want to treat the patient and not the MRI. And if somebody has a high-intensity zone, they have an annular tear, the question is that disc symptomatic? Now, what we do know is that you have an injury to the disc, and it's really almost impossible to get that without also harming or injuring some of the stabilizing structures. And so those can be evaluated, with our palpation techniques, just as they also have what sounds like an S1 radiculopathy, but many of these ligamentous tissues with the sclerotomal referrals are identical or so similar that it's hard to distinguish between the two. So one of the approaches I would probably take initially in trying to determine whether the disc was symptomatic would be to do a lumbar epidural. And I don't really do standard lumbar epidurals with high-dose cortisone anymore, but that's certainly an approach to possibly give them pain relief and also help diagnostically as to whether or not the disc is symptomatic, because I would use a platelet lysate like Paul would, and ideally, if by doing that, you would determine whether the disc was symptomatic and hopefully resolve the presumed radiculopathy into the leg. But as a secondary step, then you want to look at stabilizing the low back and treating the ligamentous structures around that area. And then I think I would take kind of the same approach, is that if you went through that sequence of events and they still didn't have adequate pain relief, that looking at injecting the disc with biologics would be the next logical step.
I don't know, maybe I'm the heretic here, but a case, was it?
You do accurate.
We'll confirm that. You're the heretic.
But how I would present that depends on, is it mild to moderate, moderate to severe? If the patient comes in with moderate to severe pain, I say you're a little too late for small needles. If it's mild to moderate, I've had this a long time, it's just bothering me when I sit down, you may want to do an acupuncture approach, and we use a lot of Craig Penn's technique. We stimulate the myotomal, sclerotomal, and dermatomal distribution. But a patient like this, truthfully, I would start very simply. Depends on where they're from also. If they come from afar, or if they're local, let's take local first. Based on I would do a Ciriax test, as per Richard. I would add one more test on the muscle resistance testing. If they're weak at L5S1, I would start, Paul, instead of the facets, the instability, I start at the nerve root. I do an epidural steroid injection, plain and simple. I keep it very simple, but I tell them this is the beginning. This is the elementary school level treatments. And I set them up. I don't say to them, we're going to do 3 injections spaced 2 weeks apart. I've gotten rid of that many years ago. I do 1 epidural steroid injection. It depends on how eager they are. If they say, I really want this thing treated successfully, I say the first thing I do is epidural steroid injection. And I tell you the truth, the second thing I would do would be a facet injection. I wouldn't start with the platelet lysate. I think that's for later on, truthfully. It's a much easier way to take care of a patient. Start with something simple that's recognized in your community. If you start with unusual, even though they can be effective, unusual treatments, I think that the amount of patients coming to see you will start dropping off, depending on your results. But start with an epidural steroid. They'll come back and say, wow, I am really a lot better. How much better? About 50%. What do you still have? Well, that groin pain is now gone. The pain down my leg is gone. You recheck their resisted muscle testing, and they're back to normal. I say, do you have any other issues? Oh, yeah, well, I have a chronic back problem. Okay, let's start with the chronic back problem. And then I'll discuss, depends on how severe it is. If they're a lot better, I say, maybe we continue, start with an acupuncture series, or do a lumbar facet injection. I want to know how much is contributing from their disc area, how much is contributing from their posterior elements. That gives me an idea. When they come back and say, oh, that didn't help me at all. The lumbar facet injection did not help at all, but the epidural did. I'm kind of thinking that they may not be the best candidates for prolotherapy or PRP in that near future. They're better candidates for maybe more of a nerve root type of treatment, epidural and acupuncture. They come back and say, the facet injection helped me more than your epidural did. Okay. So now I'm starting to think, now you're a good candidate for prolotherapy or PRP. And the discussion goes that way, depending on how they respond. Now, sometimes if I know that the patient's very unstable and they have a nerve root problem, I'll tell you the truth, what I do is I do the epidural injection. As I'm doing the epidural injection, I already start with dextrose into the facet area. I'm already starting to plan my future. I also plan my future. If I know that this is going to be, if I look at the patient and I say this is going to be a long-term issue, especially by their age, by how they're going to be needed to be treated, I will take a D5W solution, a dextrose, add it to my steroid. So I'm giving them a sweet epidural injection with steroid. And if they're coming from afar and they're going to be they're coming from a different state, and I know that I'm going to be working on their instability, it's not uncommon. I will do a D5W epidural with steroid and facets with dextrose. And I have them come back in about a month to 6 weeks. And I want to see how it plays out. If they come back and say I'm a lot better, then I'm going to go back to what I was originally supposed to talk to, is about acupuncture. Since you're doing better, you're not best, but you're better, let's do some acupuncture. So I think it's a more natural approach to do that. If they come back and say, I've been to 17 pain physicians, I've had more epidurals, I've had 25 epidurals, I've had 65 facet injections, my conversation then changes. Then we start talking about more biologics. But if they don't even know who you are, why you're even there, they came in because they saw your name on the internet, or somebody referred them who's a friend, I think it's very hard to talk to them about biologics. The biologics I use, again, are more when they've tried everything. I've been to more pain doctors than I know. You're the last one in the state that I'm visiting. that's the time to have that conversation. Other than that, my goal is to get them symptomatically better. Once I can control that, I think that they're a better candidate now to make them better. I'll talk about their gut, especially they come back and say, you didn't help me at all. All right. Now we start. This is a New York way of speaking. Didn't help me at all. It depends on your attitude. What about you? Did you stop smoking? Did you stop the processed foods? Then we start talking about gut. And the best way to do that is when you're doing acupuncture in your office, or if you're not doing it, you have the acupuncturist. A lot of them are also very well trained in nutritional treatments. They'll talk. In my office, I have my wife and my daughter who do acupuncture. And I walked into a gentleman and he said, your treatments didn't help me at all. Even though we've done some prolotherapy and he said it helped greatly, he still wanted his pain medicine. And I said, that's the thing we have to come off. We have to get you off that. And he said, well, I've been taking it for all my years and I'm on Xanax and everything. And I said, how is your nutrition? He says, I eat great. I said, you eat well, do you? He says, I eat very well. What do you have? What do you have? He says, every morning I start my day with Carnation Instant Breakfast. I said, well, of course. That's a great breakfast, isn't it? Carnation Instant Breakfast. I say, what do you eat during the day? He says, I eat, pardon my language here, but this is New York. He said, I eat guinea food. And I said, what the heck is guinea food? He says, I eat veal parmesan, or I'll take a chicken parmesan sandwich. I say, you stay right there. I call in my daughter, and I said, can you sit with this gentleman? She sat with an hour. An hour of speaking to this guy, how he's going to change his diet. He came back a month later to see me. I said, how are you doing? He says, I hate you. I said, why do you hate me? Because he said, I went out to Whole Foods like your daughter told me, and I bought a chicken, and I bought this, and I bought that. I wasted $150 because I couldn't eat it. I had to throw it away. Well, comes back a month later. He says, I've never felt so good in my life. I'm eating better. I stopped smoking. He said, I'm using half the pain medicine that I normally take because now the prolotherapy is starting to kick in. Things are taking a while. Sometimes we're looked under a microscope. And I tell them ahead of time, I say, I'm going to start the prolotherapy on you or the PRP on you. You're not going to see the benefit for quite some time. It's going to take months to make you better. We're going to follow this up. We're going to reinforce it on a month basis for at least two more treatments. But you're going to see a difference months later. When you leave me, I say a year from now, you're going to think back and say, you really helped me a lot. And that's how I kind of view this world. And like Brian does, I give them the optimal treatment first, but you have to be reasonable. I say, this is the optimal, but it all depends. I said, I'm not here to spend your money. The best patients to treat, by the way, are the kids now, the athletes, who their parents think they're going to win they're going to get a scholarship to school. Because they will spend anything for not for themselves, but they will spend anything for that kid to get better. So I had a kid with a spondylolisthesis and an L5 radiculopathy. I did the epidural. I said the best treatment, the optimal treatment, is to do PRP afterwards. I did one PRP. About 2 months later, we did a second one. This kid has got a college scholarship, and he's already trying for the pros. Now he comes back with tennis elbow, with lateral epicondylosis, throwing, pitching. They trust me now. He pivots on his toe. We treat that. But the long and the short of this is I do one thing at a time. Sometimes I'll plan, if I know I'm going to be planning my second treatment, I'm already starting to incorporate it into my first treatments. So this way it gives them a chance. It also gives them a little bit less financial burden to work with.
One thing I would add to this case, I have done intradiscal biologics on patients that had a significant disc protrusion and made their radiculopathy worse. So I try to assess that. I mean, we'll do all the other stuff, to do the prolotherapy, do OM2 evaluation. I never inject a lower back before doing an osteopathic evaluation and treatment, and explain to the patient, we're going to get you in neutral position and then spot weld your ligaments back in place, which that usually goes over pretty well. But the key thing that I've learned over doing many of these disc cases, if they have a symptomatic disc herniation with radiculitis, in that leg and they failed conservative therapy, then I'll go to intradiscal ozone with, I do a protocol that was published in the Pain Journal about 5 years ago. It was a Chinese study that they followed the patients out for 2 years, and they put hyaluronidase, 600 units of hyaluronidase into the nucleus, followed by 2 cc's of 40 gamma ozone, and then follow those patients out. And they would also do a 9 gamma lumbar plexus injection of ozone, and the patient's radiculopathy on average went away in less than 2 weeks, and the patient's disc herniation would recede very nicely. They repeated MRIs on a lot of these patients, and it showed reduction in the size of the herniation. So that's how I would shrink the herniation, and then for the annular tear, a month later or 6 weeks later, we'd do I've been putting bone marrow into the disc that Peter Everts talked about in one of those papers. It concerns me a lot. We've had patients that are trying to get up off the table after putting a couple cc's of bone marrow in the disc. I believe it's the degree, the hematocrit that we're putting in there is it's lighting that disc up, and these patients have a very tough time getting out of our offices. So I've had patients that it took us 4 or 5 hours to get them out of the office after putting an intradiscal bone marrow in there. I've been using the M-Site Pure PRP, and I'm not paid to say this. This is a need I saw. I saw they had a solution for it, and I tried it, and these patients are able to get up off the table pretty efficiently now. So I think dropping that hematocrit down in our bone marrow concentrate is helping these patients get up off the table, and they're recovering nicely, getting good effect from that. And then, of course, everything else these guys said. I just wanted to add that the ozone piece and the pure BMAC piece.
I'll get the last word. Let's go back to this case.
This case.
You got a
back pain.
31-year-old female, 2-year history of symptoms. She's got an equivocal MRI. I would love to examine her, but with her demographic, she's a case of lumbosacral instability, and the disc stuff comes second. And so for me, we'd obviously exhaust all conservative options, which she probably had by the time she saw you. She's 2 years into this, but you'd obviously exhaust all your conservative options with physical therapy and chiropractic first. But now she's in front of my office. I would likely find significant evidence of lumbosacral instability, and I would treat her. I'm the pumice guy, and I use pumice in the SI joint and ligaments. It works, 80-90% of the time in the right case. And so if she had evidence on physical examination that fit at lumbosacral instability.
Here, I'll make it easier. She had 2 kids, and in the second child, she had such severe back labor, she was in bed for 4 days. Okay?
Did she respond to manipulation temporarily?
Yes, I pulled her sacrum down and made this really loud pop, and she could walk. I've had hundreds of these.
What was your osteopathic diagnosis? We have 3 osteopaths and myself on the panel.
Pubic compression, an upslip pelvis, a locked sacral torsion, and the top of the right SI joint was so far forward my thumb couldn't reach it.
Okay. So and this is
I'm setting them up here.
Yeah. So you don't want to do surgery on this case, right? And so you try everything you can do without surgery, and she's got lumbosacral instability.
Oh, wait, I got to get better. And she said she feels great, and when she gets to the parking lot and gets in her car, it goes out again. Okay.
Yeah.
I got it covered?
You got it covered. So I treat her once a month for 3 months and tell her that we haven't had any side effects from our treatment except pretty significant soreness for several days to a week after each treatment.
I had 3 months of sacroiliitis from the last one I did.
Well, put them on a Medrol pack to get over that quick. And you see how they do, and most of these cases will respond.
Absolutely.
Okay, anyone wants to talk to me about that treatment, I'd be glad to give you the details.
Okay, questions?
And then if that doesn't work, then
so we
look
got like 5 minutes, and then we got to go to the workshop.
And if that doesn't work, then you look at the disc.
Shoot. You're it. Shoot. Ignore them. Ask anyway.
I respect the bejeebers out of every one of you guys, and at the risk of sounding like a schmuck from out of town here.
From
okay,
Chicago.
Thank you, right. Thank you, Neil, for mentioning diet, okay? One simple word, and I'm a functional medicine convert and loving it, and I think it's respectful, guys. Your new word instead of getting food, kidney, okay? Food is a disease-modifying drug. So is sleep, so is motion, so is emotional difficulty, so is stress. We started this conference by saying we need to treat all our patients. When you guys are mortal, just like everyone will treat me or all that, we get sucked in their own BS formulas, and these are all wonderful, and you're not BS and all that, but we forget the big picture. I'm done.
Yes?
Yeah, so if you could speak a little bit about, you mentioned interosseous injection or interspinous ligament injection. So I've had a case of I've had a rash of patients, 3 of them. I put like 2 cc's of 1% lidocaine in the interspinous ligament between like L3, L4, L4, L5, whatever it may be. And the patient gets off the table, it feels fantastic. Can you guys talk about that a little bit? And is there, in your clinical experience, have you noticed like disruptions or tears in these ligaments and physopathies or whatever it could be?
I'll take this one. I have a small case series of supraspinous ligament full thickness tears off the spinous process. You don't see them on ultrasound that easily. You have to kind of tease them out. One patient fell off. He was a military person. Fell out of a helicopter after it got hit by a enemy's grenade or something like that. Knocked him out of the helicopter. He fell about 15 feet and landed on his head. And he had chronic pain at the base of his neck for the next 25, 30 years. And I evaluated him. He'd been seen by prolotherapists before everyone did all their treatments. He had this persistent pain. So I went down under ultrasound and injected the supraspinous ligament at T1, and the ligament just lifted off the spinous process. It was not connected. So I did a big fenestration procedure and put some PRP or something like that a couple of times, and it healed back down and his pain was gone. So I've seen that now a few times down in the lumbar spine and up in the cervical thoracic junction. And it is an entity that we should be on the lookout for, and it usually responds to our treatment, but sometimes you need to get it pretty aggressive with it.
Yeah, I see interspinous ligament tears. I treat a lot of police officers. They wear these very heavy gun belts. They get into these car accidents. And actually, the MRI, I was surprised, the MRIs are showing it. And if you put your lidocaine in there, it helps. I would definitely start with prolotherapy first. And believe it or not, it's covered under workers' comp in New York, which is very rare now. Even PRP for that patient was covered. I did it twice because they saw it black and white on the MRI. So when it went to peer review, it was very simple. I was able to, and I have had I've had an N of maybe 3 or 4 that I've done this on, especially these high-end, rear-end impacts of motor vehicle collisions, and it's helped a lot.
Frank Willard presented at this conference about 8 years ago showing that our concept of the way the fibers run in the interspinous ligament is completely wrong. They're continuous with the ligamentum flavum and innervated the same way. And so, he's the anatomist at University of New England in Maine, and I'm pretty sure he published it, so you should be able to find it. What Netter writes is completely wrong. They run this way, not that way.
I just treated a 16-year-old crew kid that had bad mechanics and thoracolumbar junction. We treated his supraspinous, interspinous, but also the facet capsules on either side, very localized at a couple levels. One treatment with PRP, and he was 60, 80% better. He needs another treatment. But
if you look up Clay Shoveler's fracture, the same guy wrote up about Clay Shoveler's syndrome, which was a tear of the nuchal ligament at C7T1. And it was lost, but when I was a fellow, they made me go in the basement and find it. It was really dusty. I had to wear a mask. You're last. Okay, you're next to last. Go ahead.
For 25 years before PRP and all this other stuff came along, I did prolotherapy for 25 years, seeing, I can't say hundreds, but tens of dozens of patients with this type of symptomatology who I didn't find an SI joint off or whatever, but they had a small disc bulge in their MRI and they had some particular symptoms. And I treated them with Prolo. Sometimes they didn't get better the first time, but after the second time, and 90+% of those were totally cured with dextrose prolotherapy. And you do the lumbar spine, you do the SI joints, cover it all, you stabilize them, and the discs resolve eventually, and the nerves get better. I used to, if they had a really hot disc, do steroid into their coddle epidural, calm them down, and that always did it. Mostly, if they didn't do it, now I would use D5 and just do a coddle epidural.
By the way, there is a poster presentation on repeated D5W caudal epidurals, showing that it really works. The take-home message for me from this panel is, notice no one said, oh, I treat that disc first. All of us treat it last, if needed. So, some people are so discocentric with the ball that's been, no, never mind. That they go for the disc, they think the disc is the pathology, and so it's a plug for my lecture tomorrow, which is learning from what everybody here will teach you, mentor you, about how to figure out not the pain generator, but all the overlapping pain generators. Then very few of us treat discs. I mean, I've taken the stupid disc course so many times that I could probably put the blindfold on, and I have not put a needle in a disc yet. That doesn't mean people didn't need it, but almost everybody got better from other interventions. He says, standing here uncomfortably with his back pain of 41 years. So we're going to finish up so that we can move on to the workshops and not miss the workshops. Yep. Go ahead.
Yeah, that brought up a really good point about the disc. I just wanted to add one last thing. I've had patients that had a high-intensity zone in a disc, and they presumed pathology was there in the pain generator and gone through a lot of different treatments and epidurals and stabilizing structures, and they still had pain, and do a discography, which I don't have done very often, but if you're really pushed up in a corner and you can't figure out what the problem is. And I've had patients that had very clear high-intensity zone, and you presume that just the disc is causing the pain, and have a discography done, and they basically have an asymptomatic annular tear with a high-intensity zone, and the disc was never the source of the pain.
All the time. There's also some I don't know if it's been published, but there are platelet lysate studies showing that platelet lysate transforaminally, improves the symptoms and may be responsible for the discs retracting. It's kind of apples and oranges a little bit to me, but discs heal on their own if you stabilize the system. So the Saul brothers a very long time ago showed that even with severe radiculopathy with motor and sensory symptoms, if you teach them really good lumbar stabilization so they don't re-torque the disc, they'll heal all by themselves. So, so we've been doing non-surgical discs since the 80s through just proper rehab. Right.
Thank you, thank you.
You're welcome. Take this way. You're all set.
This was terrific. That's the beauty of this society. You got guys coming from different perspectives, different residencies, different fellowships. There's a lot of different ways to skin a cat to get to a good result, and you see it here. We still don't agree as to what the exact approach should be, and it's probably because there's multiple ways to get a good success for your patient.